air leak or that hole, heal over time. And then the idea is that you then take the valve out. So this is proximal, this is distal, and again, this is where we would pull it out. So the Zephyr valve, so this was exciting because, this is a valve that we were involved in a study many years ago, but it's a one-way valve, again, allowing air to come out but not go in. It could drain secretions, it's silicone, and we can do it through a flexible scope. We did do it under general anesthesia, and they're designed to be removable. But in some situations, they're not, similar to a stent, because it's a foreign body, it can incite an inflammatory response, and some of these people can get very exuberant granulation tissue. So this is the valve open during expiration, and this is the valve closed during inspiration. So most recently, the Liberate trial was done, where they looked at 190 subjects who had severe heterogeneous emphysema and no collateral ventilation, based on some other measurements and imaging studies that they did. Random assignment occurred to get the Zephyr valve or standard of care, and they followed people for 12 months, which was a bit longer than the event study that was initially done. 48% of the people with the valve and 17% with standard of care had improvement in their FEV1. And then between groups, there were differences that were all significant for FEV1, 6-minute walk, shortness of breath, and quality of life. They did have a fairly large number of pneumothoraces, that got treated and managed. But this then actually led to this summer having the Zephyr valve approved by the FDA for treatment of emphysema. So this is now starting to be used at select centers as the company tries to start kind of rolling it out in a controlled fashion, because obviously what you don't want to do is sort of let it be out there and then everybody starts getting valves. That's not how we want to do these things. All right, so we're going to wrap up with the mechanical side of asthma. So again, asthma is a chronic obstructive disease that causes a lot of morbidity in this country, characterized by airway hyperresponsiveness, obstruction, mucus plugging, and then kind of what we focus on from the bronchoscopic standpoint is airway smooth muscle contraction, caused by a variety of triggers, and you get increased mass of the airway smooth muscle. So bronchial thermoplasty is a procedure where we deliver radio frequency energy to the airway wall with the goal of reducing the contractile ability of the smooth muscle. And the utility, again, is based on the idea that then blocking that airway smooth muscle will cause amelioration of their symptoms and reduce their exacerbations. So basically, the tissue is heated to 65 degrees. And pathology studies have shown that the airway smooth muscle is gone, but the remainder of the tissue is okay. And so what the procedure is this is in patients who have severe persistent asthma, unresponsive or continuing to have problems on current therapy, not having really frequent exacerbations, not having a lot of other comorbidities. And basically we treat all of the airways that we can reach with our device. It's an expandable basket that has 4 arms, and basically each of those arms has to make contact with the airway. And then we target airways distal to the mainstem bronchus down to about 3 millimeters. So basically you go in and you treat, and then you pull back, and you pull back, and you pull back. So these are procedures. We do 3 procedures on patients. So the initial procedure, we treat the right lower lobe. 3 weeks later, we treat the left lower lobe. And then 3 weeks later, we treat bilateral upper lobes. We skip the middle lobe just to try to avoid any issues with developing stenosis or problems there. All right, so this is just, in initial animal studies, this is the airway that was treated with the thermoplasty, and this is the airway that was untreated. And then they did local application of the methacholine. You can see that this airway constricted down, and this one stayed relatively open. And similar things have been found in humans. So the FDA approved this for severe persistent asthma and having symptoms despite high-dose steroids and LABA. They're non-smokers, not having life-threatening exacerbations requiring intubations, not having a bunch of hospitalizations, not having a super low FEV1. And again, this is kind of what the procedure is. And we do them. Again, it's in very select patients, like many of these procedures are. And I think we need to do more trials to figure out who they're going to be most beneficial in. So in conclusion, so hopefully you guys can see that a flexible bronchoscope can be a really valuable tool for a lot of indications, ranging from simply looking and inspecting an airway to doing more advanced procedures for helping people with central airway stenosis, and now starting to do things in people that have chronic obstructive lung disease. Again, the choice of intervention that we do is largely institution and physician dependent, so there's not always a right answer. This is what you have to do, as many things are in medicine, but these are some of the things that we have. And I think that's one of the exciting things about bronchoscopy is that we are having more and more tools that we can use to help people and to help people feel better. And then again, bronchoscopy has found a role in select patients with obstructive lung diseases. So, thank you. Any questions?
Thank you very much. Is there any questions? No.
Okay. Thank you.
Thank you very much. We are going to